Hello, esteemed committee members, faculty, and colleagues. My name is Mikelle Swafford, and this is my presentation entitled Assessing Overweight and Obesity, Whose Job Is It Anyway? My committee members included my project chair, Jennifer Hepner, the second reader, Jennifer Brunworth, and my community member, Kristen Stringer. The purpose of this Doctor of Nursing Practice project was to improve how primary care providers identify, discuss, and manage overweight and obesity. To achieve this, we introduced a structured patient encounter tool designed to guide providers through sensitive weight-related conversations and improve confidence in treating this stigmatized condition. The aim was to improve both provider communication and patient outcomes by promoting more consistent diagnosis and evidence-based management of overweight and obesity in primary care settings over an 8-week intervention period. Obesity has long been misunderstood, but in 2013, both the World Health Organization and the Centers for Disease Control and Prevention officially recognized it as a chronic disease. Despite this, negative attitudes persist in healthcare, contributing to inconsistent care and poor outcomes for people with obesity. Studies have shown that weight stigma in healthcare can lead to physiological and behavioral effects like increased cortisol levels, disordered eating, and avoidance of physical activity, which worsen obesity. Many providers also lack formal education in the biopsychosocial aspects of obesity. In one study, nearly 40% of medical students had no training in this area. Addressing this gap in education and stigma is critical. Overweight and obesity affect more than 40% of adults in the United States, and the approach providers take in discussing weight directly impacts patient trust, engagement, and long-term health. This is the patient encounter script and the 6 A's communication framework. As you can see here, the patient encounter script involves showing interest and compassion in the patient's personal struggles with their weight and identifying whether they are ready to move forward to improve their health. Here, the 6 A's communication framework includes asking the patient for permission to discuss their weight, assessing things like their BMI, weight, and other details of their life that may affect their weight, advising the patient on different weight management techniques, agreeing with them to establish trust in the relationship, assisting the patient with finding appropriate individualized treatment options, and arranging scheduled face-to-face time with the patient for follow-up and ongoing support. After the patient encounter, it's always important to reflect on whether the visit was an appropriate, stigma-free meeting and whether you followed best evidence-based practice. A review of the literature confirms that overweight and obesity significantly raise the risk for chronic illness such as type 2 diabetes, hypertension, and cardiovascular disease, and are associated with increased mortality. Despite these risks, providers often fail to diagnose or address obesity due to discomfort, limited visit time, and concern about stigma. Studies have shown that weight bias, even when unintentional, can negatively impact how providers communicate with patients and discourage meaningful conversation. Structured communication frameworks like the 5 A's and the expanded 6 A's help guide this discussion in a respectful, patient-centered way. These models provide a consistent structure for addressing weight while promoting shared decision-making. Research supports that used structure tools can increase provider confidence and improve the quality of counseling. Importantly, studies also show that their use leads to better documentation and higher rates of obesity diagnosis and treatment planning. This project was guided by the Plan, Do, Study, Act, or PDSA framework, originally developed by Walter Schuhart and later championed by W. Edwards Deming. The PDSA model is widely used in healthcare for implementing small-scale changes that lead to ongoing quality improvement. It was well suited for this project, which sought to enhance the diagnosis and treatment of overweight and obesity in primary care. During the planning phase, I applied the FOCUS tool, which stands for Find, Organize, Clarify, Understand, and Select. This helped identify gaps in provider communication and determine the most appropriate tool for implementation, ultimately guiding the selection of the patient encounter tool. The Do phase, I worked closely with stakeholders and my faculty advisor to deliver clinician training and support sensitive communication strategies for working with patients affected with obesity. The Study phase involved analyzing pre- and post-intervention data, and in the final Act phase, the project's success supported its potential for broader implementation across other primary care clinics. This project followed a quality improvement framework utilizing a pre- and post-intervention chart review design. The intervention was a structured patient encounter tool based on the 6A's communication framework: ask, assess, advise, agree, assist, and arrange, which helped guide clinicians in initiating respectful, patient-centered conversations about weight. Providers at the primary care clinic were trained through 2 structured educational sessions where they received laminated scripts of the tool. Training supported integration into workflow without significant disruption. Retrospective data were collected from the EMR comparing clinical encounters from 3 months before to 5 months after implementation. No patient identifiers were recorded, ensuring HIPAA compliance and ethical integrity. The design allowed the team to assess changes in diagnosis and treatment documentation while minimizing risk to patients. The sample for this quality improvement project consisted of patient electronic medical records from a single primary care clinic. To ensure relevance, only records of English-speaking adults, patients aged 18 to 65, with a body mass index classified as overweight or obese, which is a BMI of greater than or equal to 25, were included. Pregnant or lactating individuals, those outside the age range, or those without elevated BMIs were excluded. Data were collected retrospectively over 2 defined periods, the 3-month period before and 5-month period after implementation of the patient encounter tool. Patients were not directly contacted or involved, and their identities were protected by excluding all identifying information. Although the intervention was implemented during routine care, patients retained autonomy and could decline weight-related discussions, reinforcing ethical care standards. The project author had no prior relationship with participants aside from completing a clinical preceptorship at the site. This sampling approach supported ethical and methodological sound data collection while focusing on a population directly impacted by the project's goal: improving the diagnosis and management of overweight and obese in primary care. This project used nominal data to compare the proportions of overweight and obesity diagnosis before and after implementation of the patient encounter tool. The primary variable of interest was whether a diagnosis was made, categorized as either present or absent. Because we were comparing 2 independent groups, the Maryville University statistician recommended using a z-test for 2 independent proportions to evaluate the significance of the observed change. The independent variable in the study was the use of the structured patient encounter tool, while the dependent variable was the rate at which providers documented diagnosis of overweight or obesity. A minimum sample size of 102 patients was required to achieve statistical power of 0.8, which ensures sufficient sensitivity to detect a meaningful difference. We had a total of 151 patients by the end of the study. In addition to diagnosis rates, the data collection process also recorded other clinical actions such as diet and exercise counseling, medication management, and referrals. These were not part of the statistical test, but were analyzed descriptively to provide additional context regarding the intervention's impact on clinical behavior. Data analysis included 151 patient encounters, 84 before and 67 after implementation of the patient encounter tool. Following the intervention, documentation of overweight or obesity increased significantly from 41.7% to 64.2%. A z-test for two proportions confirmed this was statistically significant with a p-value of 0.003 and a power of 0.87, indicating a robust finding. Treatment strategies also became more varied, with increases in patient education and diagnostic referrals. While lifestyle counseling slightly declined, this may reflect a more individualized approach to care. Figures and tables on this slide and the last help illustrate the positive shift in both diagnosis rates and treatment patterns after the tool was introduced. While this project demonstrated meaningful improvements in obesity diagnosis and care, it also encountered several limitations. Not all clinicians fully adopted the patient encounter tool, often due to time pressures or discomfort with initiating weight-related conversations. Documentation inconsistencies in the pre-intervention data may have led to underestimates of treatment, making comparisons more difficult. Additionally, the project was limited to a single clinic, which, along with the small sample size and brief implementation period, affects the broader applicability of the findings. Provider resistance was the most significant barrier. However, consistent use of the tool improved when the project author was present and reinforcing its values. Long-term success will depend on integration into a clinic system and sustained leadership engagement. The results from this quality improvement project demonstrate the value of using a structured patient encounter tool based on the 6A's communication framework. Following its implementation, diagnosis rates for overweight and obesity increased significantly from 41.7% to 64.2%. This improvement aligns with the past research, emphasizing how structured, patient-centered conversations can improve provider confidence and care delivery. A major strength of this project was how smoothly the tool integrated into existing clinical workflows. It was easy to use, time efficient, and well received by providers when support and reinforcement were present. While some resistance was encountered early on, leadership engagement and continuous communication played a key role in fostering adoption. These results not only reflect better documentation, but also suggest evolving provider behavior as treatment strategies became more personalized. Overall, this project highlights the positive impact that targeted communication tools can have on clinical practice and patient outcomes. Implementation of the patient encounter tool based on the 6A's framework led to meaningful improvements in how overweight and obesity are identified and managed in primary care. By increasing diagnosis rates and encouraging more personalized treatment strategies, the tool demonstrated practical value for everyday clinical workflows. These findings align with national public health priorities and support integrating structured communication tools into EMRs and provider education. Importantly, this tool also promotes quality and safety by reducing variability in care, improving documentation accuracy, and decreasing the emotional harm caused by weight stigma. Sustainability efforts, including EMR integration, staff training, and clinic champion engagement, are essential to maintaining long-term effectiveness. Looking ahead, dissemination to leadership, quality improvement committees, and academic journals will help scale the tool's impact across other healthcare settings. This DNP project allowed me to witness the direct impact of structured, compassionate communication on clinical practice. The patient encounter tool significantly increased diagnosis rates of overweight and obesity, from 41.7% to 64.2%, demonstrating how a simple, evidence-based intervention can improve patient care and provider behavior. It also fostered more personalized treatment planning, including increased use of educational referrals and diagnostic workups. These outcomes support the use of tools like the 6A's framework to enhance provider to patient communication in a respectful, stigma-reducing way. On a personal level, this project was a transformative journey. I grew not only as a provider, but also as a person. I learned that I am more resilient, determined, and capable than I ever gave myself credit for. I pushed through uncertainty and self-doubt and emerged with a deeper sense of confidence and clarity in my role as a nurse practitioner. This program challenged me in ways I never expected, but through it, I discovered strengths I didn't know I had. Professionally, I now feel prepared to lead change, mentor colleagues, and advocate for improvements in primary care practice. I understand how to design and implement quality improvement initiatives and how to ground them in evidence while honoring the humanity of the patients we serve. As I move forward, I hope to expand this work, integrating the patient encounter tool into clinical systems, engaging stakeholders, and ensuring long-term sustainability. The DNP program has left a lasting mark on me. It's strengthened my voice, expanded my knowledge, and gave me the tools to make meaningful change. I will carry this experience with me into every clinical encounter and leadership opportunity ahead. Here is a list of the references that supported this project. This work represents 3 years of dedication, perseverance, and growth. Truly a labor of love and determination. I sincerely appreciate you taking the time to listen to my presentation today. Wishing each of you a happy, healthy, and safe summer. Thank you again, and goodbye.